We have been thinking about situations where people are at risk of prolonged seizures or risk of status epilepticus or have already been having these kind of situations, and we think that in many cases we in fact don't anymore wait. For example, in hospital settings, we don't anymore wait for 5 minutes the seizure to last before we intervene. For example, in video monitoring unit, that is not happening. And now it's contradictory to say that in our guidelines that you should wait. And therefore we are now talking about rapid emergency seizure termination. So as long as you find out the situation, you have the emergency medication, for example, buccal midazolam, and you know the patient at home also or hospice or wherever, you can already stop the seizure after like 1 or 2 minutes when the situation is clear and you have the medication. This is what we call now rapid emergency seizure termination, REST. This is for selected patients, not everybody, and of course you need to have somebody to really take you the medication according to the instructions. But this is for those patients that have active treatment, but this is of course also for everybody who are in palliative care. And this might prevent in fact unnecessary hospitalizations, unnecessary road trips with ambulances for patients that are in fact dying. So I'm saying that we should very actively treat also seizures in those palliative patients. I'm not saying that we wouldn't treat them, but we should more actively treat in the beginning, but then we shouldn't perhaps anymore go to the intensive care units in an unnecessary way.